Well, I'd like to welcome everyone to Harnessing the Power of Mind-Body Medicine with Mark Weisberg, Ph.D. And I look so forward to sharing more about Dr. Weisberg's background and introduce him to you a few minutes from now. I am Ed Glauser, the owner and principal clinician with the Mind-Body Medicine Network and your host for our webinar. So I would like to first introduce Heather Butts with Learn for Life Consulting, LLC, our producer for this evening, who will go over the technical aspects of our webinar experience. So welcome, Heather.
Thank you so much, Ed. It's a pleasure to be here and to help with any technical issues that may arise for you during our webinar. So first, you can either listen to the webinar from your computer by clicking Listen in the information area of your control panel, or call the meeting burner phone number and enter the PIN number also listed in the information area of the control panel. It is highly recommended that you use the phone line in case we have any technical issues on the meeting burner platform. That phone number is on the control panel listed under information. Also, you will now need to find the down arrows next to the host and information areas of your control panel and click on those down areas to expand the chat area you'll be using for the rest of the webinar should you have any technical or content questions throughout the webinar, and for questions and comments after Dr. Weisberg concludes his presentation. Please put any comments in the chat area, and please do not use the Ask a Question area. And now I would like to turn it back over to Ed Glauser, the host of our webinar.
Heather, thank you so much, and we're so fortunate to have Heather Butts with us. She is also a collaborator on our Mind-Body Medicine Network sleep training program, so we're thrilled to have her with us, helping us with the technical aspects of tonight's webinar. So you'll see our website for more information on all of our offerings, including our blog talk radio shows on sleep health with Heather Butts, and our full listing of webinars and webinar recordings. And now, the Mind-Body Medicine Network presents Harnessing the Power of Mind-Body Medicine with Mark Weisberg, Ph.D., and I would like to read a little bit about Dr. Weisberg's background. Dr. Weisberg is a clinical health psychologist and co-owner of the Minnesota Head and Neck Pain Clinic in St. Paul, Minnesota. He is board certified in clinical health psychology, American Board of Professional Psychology. He is a community adjunct professor in the Academic Health Center at the University of Minnesota. Dr. Weisberg has been involved in clinical practice, consultation, and teaching nationally and internationally for the last 25 years. He is the co-author of Trust Your Gut, an integrative medicine book for healing digestive distress, to be published by Conari Press in early 2013, and you'll be able to click on Dr. Weisberg's website for updates regarding his release date, and you'll see his website listed here as well as at the end of our webinar. And on a personal level, so much of what I have learned about mind-body medicine comes from my mentor and friend, Mark Weisberg. I was able to have Dr. Weisberg as one of my primary supervisors as I worked on and received a certification in both mind-body medicine and clinical hypnosis, and it really was the most valuable learning experience of my professional life as a clinician, and it really is due to Dr. Weisberg's outstanding affirmation and guidance that led me to establish the Mind-Body Medicine Network. So if it wasn't for Mark, we would not be here tonight. So Mark, with that introduction, take it away.
Wow, Ed, I'm really touched, and thank you for that wonderful introduction, and it's a pleasure to be with you and with the audience and the group that's joining us, and hope that this will be a useful presentation, that the information will be practical and things that people can take and to bring to their practices.
Wonderful.
So
thank you
that,
so much, and we will go ahead and advance for the goals of this workshop.
Sure. Okay, so part of mind-body medicine that I find people often misunderstand, whether it's clinicians, hospitals, health systems, or whatever, is they think of mind-body medicine simply in terms of techniques. But it's really a whole different system of understanding health and illness. And so one of the goals here is to learn about what's called psychoneuroimmunology. That's a field that we'll talk about, and it helps describe some of the physiological nuts and bolts, if you will, of how and why mind-body phenomena take place. So we're going to cover some about what that is and how it can help you to better understand and treat various kinds of conditions that you may come across in a mind-body practice. That includes autoimmune conditions, all kinds of acute and chronic pain, and digestive problems such as irritable bowel syndrome, but other digestive problems too, such as GERD or reflux disease, Crohn's and colitis, things like that. There are many different types of techniques that can be used within a mind-body medicine model. And one of the ones we'll discuss is clinical hypnosis. And we're going to talk about why, from an integrated medicine perspective, hypnosis is such a good fit and works so well for the goals that one should have working in mind-body medicine. Another piece of understanding mind-body medicine is that it indeed is a new paradigm. Although it's been in the media and people have heard about it for some years now, it's still relatively new relative to the traditional health system. And it's very important, if you are a clinician working in this area, to be able to explain mind-body medicine to your patients, to referral sources, people that send patients to you, to hospitals, clinics, the public, and to be able to talk about what it is and how and why it works. In the same way that if someone was going to recommend a medicine, they have to be able to say, here's what the medicine is, here's how it works and why it works. So same thing here. Now another aspect here that's important is in mind-body medicine is the one important goal is to activate the self-healing resources within the patient. And I have found over the years that there are certain characteristics of the healer that will maximize the patient identifying those self-healing resources. That's part of what we'll cover. And also, when mind-body medicine doesn't work, sometimes it's because there have been obstacles. It might be resistance in the patient. It might be resistance in the clinician. It might be things in the therapeutic system. But whatever they are, to be able to identify them and have skills to overcome them is crucial. So we'll talk about that as well. I am very excited to let everyone who's listening know about this book that is about to be released probably in February. It's called Trust Your Gut. Actually, the full title is Trust Your Gut, Healing Irritable Bowel and Other Stomach Distress Without Drugs. And it will contain much of the underlying philosophy of integrative medicine that we're going to talk about tonight and apply it specifically to digestive disorders. It's a consumer book, it's meant for the average consumer, and written with my colleague Greg Plotnikoff, who is an integrative internist and pediatrician. And we're very excited about it, so I just wanted to alert people to that and to look for that. As Ed said, you can go to my website to get updates about when the book will be released. Okay, so with that, I would argue that in order for optimal healing to occur, in order for the clinician to optimally stimulate self-healing in the patient, there's 3 messages that must be conveyed, and these are messages that are conveyed not so much by saying the words, but messages that are conveyed non-verbally. The first one is, I'm here with you, paying very close attention. Now, that doesn't mean that you say to the patient, I'm here with you, paying very close attention. It's more all the nonverbal ways that's conveyed. So, Ed, for example, what would you think of in terms of nonverbal ways that you convey that message?
I think your body language, and you can see if a person is stressed or withdrawn or agitated. That would be a sign for me.
Mm-hmm. Sure. And all the other things that most of the listeners here probably are already aware of, even if they don't think of it under these terms. Matching the patient's breathing, matching their body position, all those sorts of things. When you watch, in your training, whenever you watch videos of good healing encounters, you see that this happens naturally. That the clinician will kind of automatically match the patient's breathing, match their bodily position, facial expression, things like that. So that's one message. Another one is, do you know that there's aspects of your functioning that you weren't aware of? That might be part of their mental functioning, or physical, or emotional, or spiritual functioning. So, for example, if I said to a patient, are you aware that when you talk to me about your neck pain and your shoulder pain, your face starts to look sad and your eyes seem a little teary? Why is that important? This is important because, especially in chronic illness, these patients have been to anywhere from 5 to 10 or more different clinicians, going through all kinds of tests and procedures, often with no relief. And by the time they get to you, they feel at least skeptical or perhaps even hopeless that anything can be different. So when you point out something that they have not had pointed out before, that engenders hope because you're bringing up something different. That ties into the third essential message. Patients with chronic illness, by the time they get to you, may feel like it's hopeless and that change is not possible. And your job as the clinician is to convey that change is possible. But again, not so much by saying change is possible. Because if you say that too soon, or if you say it verbally, you'll lose credibility because you won't meet them where they are, because their experience has been that change isn't possible, or else they would have changed. So, for example, any time that I see a patient, no matter what we're working on, I make a point that we always address certain brief experiential exercises so that they experience some kind of shift. Even if they just take a deep breath or two, or if we go through a brief breathing exercise, or I do something else with them so that they start off feeling one thing and then feel something else. I really capitalize on that and say, notice that you did this breathing technique and your tension in your stomach was at a 6 and now it's at a 4. That changed. And so the implicit message there is it's possible for things to change. And the other implicit message is just as this changes, so may other things change as well. So those are the three essential messages that I think any real solid clinician conveys every time they see their patient.
Mark, that's just wonderful, and those are some of the guiding messages that you shared with me in my training. I did have a question, because there were some other essential messages that you have shared with me over time, and I didn't know if they were part of the essential messages or more ancillary, but I'd like to raise them briefly and get your response. That we all have our own unique set of psychophysiologic triggers would be one, and just like you mentioned before, that it's important to focus on the little changes, that we don't want to just measure change and healing by something significant, and that giving people the space to heal in their own time, at their own pace, and in their own way. So I wanted to get a response from that, if you felt like those were some very important essential mind-body medicine messages as well.
Yeah, again, particularly dealing with chronic illness, where a lot of patients get tripped up is, when someone has a chronic condition, the healing process is often slower because it took a longer time for the symptom to develop. That when you have a symptom over a period of time, we as humans tend to develop relationships to things that have been part of us for a while. And so let's say you have low back pain, and let's say you have a surgery to correct a bulging disc, but a year later you still have back pain because the muscles around the area have tightened. Your pelvic girdle may be tighter and less flexible because the psoas muscles in front, or the piriformis in the back, or the iliotibial bands on the side start to tighten up unevenly. And so change in a chronic condition happens slowly. And so you bring up a really good point. It's very important to educate the patient early and often that we're looking for small changes in the symptoms. That's how the phrase I use is, that's how we're hardwired to change. So that when a patient comes to me and is discouraged and said, geez, nothing's changing, I'm afraid the treatment's not working. And then I can point out, well, didn't you just tell me that the pain went down from a 7 to a 5 over the past week? And didn't you, then you point out these little steps of things that they've told you. And you say, it's really important that you don't underestimate the importance of these small changes, because the way I frame it is, small changes are the ones that last. Big changes oftentimes may reflexively slip back into the initial symptom. So yes, I think educating patients about that is really important. The analogy I sometimes use, or the metaphor, is I tell patients that when you're dealing with healing from a chronic illness, it's kind of like swimming in the ocean. In that, if you're swimming in the ocean and you look to the side, you don't see any yard markers. You don't see any milestones. You just see there's more water and more water. It's hard sometimes to tell where the progress is. And so identifying these small changes are not only important because that's the way change occurs, but also important because it engenders more hope. And when the patient experiences a small change, they can feel some encouragement about that, and that really helps the healing process.
Well, thank you so much for expanding upon that, Mark.
Yep. All right, so back to the issue of, as the clinician, and regardless of what kind of clinician you are, whether you're a psychologist, physician, nurse, social worker, psychotherapist, physical therapist, psychiatrist, body worker, acupuncturist, whatever kind of healing person you are. When we get back to what is it that increases or catalyzes those self-healing capacities, presence and silence are really important. What does that mean? Being present with the patient. You know, when you think of back a number of years ago, the Menninger Foundation that used to be in Topeka, Kansas, and now is down at Baylor, I believe, did this huge meta-analysis of what are the most important variables in successful psychotherapy. And they looked at everything. They looked at diagnoses. They looked at how long did the patient have the condition, comorbid conditions, medications, socioeconomic status, etc. The number one variable they found that predicted success in treatment is if the patient rated the clinician as being with them in a good quality therapeutic relationship. That was rated higher than any other variable in predicting success in treatment. A quick story to illustrate this. A number of years ago, I went to a workshop with someone named George Leonard, who's unfortunately no longer with us, but he was a writer for Esquire magazine. He wrote a number of books about mastery, how to achieve personal mastery, and also was a fifth-degree black belt in Aikido. So he combined some very interesting skill sets. And we were in this workshop. There were about 15 of us, and he had us do this exercise where he says, okay, now take your little finger on one hand and bend it back as far as you can until it hurts. So we did that. He says, all right, now I want you to pair up with someone else in the group, take a minute or two, and just establish a connection with them in whatever way you can. And so we did that. He says, now bend the finger back again and see what happens. But every one of us, including me, were able to bend the finger back not only much further, but with way less distress after connecting with a partner where we felt some good connection. The point being, this speaks to the Menninger studies and to what healers have known for centuries. There's something about the therapeutic presence in the therapeutic relationship that allows the patient to let themselves experience things that they would not let themselves experience otherwise. And that's extraordinarily powerful. And so it's your presence in the therapeutic relationship, whatever you're doing, whether you're doing a treatment, whether you're doing hypnosis, whether you're giving an injection. Even just the power of, let's say you're giving an injection to someone and saying to them before you give it, and just gently put your hand on their arm and say, when you first feel the needle enter your skin, that's going to help you know that the healing process has begun to happen. Your words and your reassurance really maximizes and potentiates that treatment. So that's presence. Silence means that you don't want to be more invested in the patient's healing than they are. You want to be with them in a way that generates and supports their self-healing, the presence I just talked about, but then stay the heck out of the way. If someone is, while they're working with you, is sad, if they're scared, if they're panicky, if they're angry, the extent to which you can be with them with the truth of their experience, and being aware of your own impulse to want to hand them the Kleenex box or do something to calm them down or soothe them, sometimes those emotional reactions are exactly what they need for the self-healing to kick in. And for the clinician being able to sit with their own discomfort enough that they just stay silent but stay present with the person, often helps them to get through a very difficult obstacle and to experience some self-healing. So it's kind of like a martial arts practice. You want to be present but also silent at times when they experience difficult things and just need to be with it sometimes. So that's what those two things mean. Now, there's also some important assumptions, I think, in doing effective mind-body work. The first is you got to pay attention to the body. The body is one of the most reliable messengers of information that's been out of awareness only if you know how to read it. So paying really exquisite attention to the most minor changes in posture, in breathing, in facial tone, facial color, eye movements, all those things are part of that information. If we think of health and illness as a psychophysiological pattern, which we'll get to in a little while, a psychophysiological pattern being a combination of emotions, physiology, thoughts, images, behavioral impulses, sense of identity, that all work together synergistically. From an integrative model, a symptom means some aspect of that pattern's been cut off. The thoughts have been cut off from feelings, the sensation's been cut off from memory's been cut off from behavior, something like that. We'll talk more about that in a minute. Another assumption, what I'm conveying here is that it's not that talk isn't important. Talk is crucially important, but the most profound change occurs when the talk, whatever words you use, lead to a change in experience in the patient. The most profound change comes from experience, a shift in experience. So our talking, whatever we say to the patient, should be aimed towards a change in experience. Self-healing systems we've already talked about. And the paradoxical law of change, which states, when you accept something exactly the way it is, it changes. Conversely, the more you try and fight certain symptoms that are there, the more intransigent and the more stubbornly stuck they become. So those are also some of the assumptions that I'm always keeping in mind whenever I'm treating a patient. All right. So, Ed, let me just do this with you.
Okay.
Why don't you, and pretend that I have not had this talk with you already.
Okay.
But I want you to answer this being like the typical clinician who's maybe somewhat newer to mind-body medicine. And I want you to just list mind-body treatments.
Well, when I think of mind-body treatments, I think of yoga or hypnosis, or a lot of the energy medicine modalities, bio-neurofeedback that can combine, somatic experience with, a cognitive and a visceral effect.
Yep, sure. And people might name other things like massage or Reiki or St. John's wort or traditional Chinese herbs or things like that. What people usually don't name are things like surgery or medication or physical therapy or trigger point injections. But the point being is that what makes something a mind-body treatment is not whether it's EMDR or energy medicine versus surgery. Any treatment we know of can be a mind-body treatment, or anything we know of could be a traditional mechanistic allopathic treatment, depending on our assumption of what we think is causing healing or causing disease. I'll give you a quick example. Let's talk about Prozac for a minute. People usually don't, when I ask people this question, name mind-body treatments, they usually don't mention Prozac. But Prozac can be a mind-body treatment, or it can be a mechanistic treatment. Here's an example. here's the way it'd be used as a mechanistic treatment. If you go to your clinician and you're depressed, the mechanistic use of Prozac would be as follows. They would say, okay, so you're depressed, and that's because you don't have enough serotonin in the synapse between your neurons in your brain. And so, don't worry. It's got nothing to do with how you live or how you eat or how you deal with emotions. It's just a biological abnormality, very, very similar to when you're diabetic. It's just your pancreas doesn't produce enough insulin. You get the same thing. It's just that your brain doesn't retain enough serotonin in the synapse. So we're going to give you this Prozac, and you're just going to have to take it for a long time. And that will keep more serotonin in the synapse. And you'll just take it for a long time, and that will help you with your problem. Okay, that's a mechanistic use of Prozac. Now, what would be a mind-body use of Prozac? That would be as follows. Okay, so you're depressed, you're having problems sleeping, you feel hopeless, you have low energy, or you might be quite agitated. You've tried various things, but you can't get unstuck. So I'm going to give you this Prozac for a few weeks as, or a few months, as an experiential reference point so that you can feel what it's like to have more energy, so that you can feel what it's like to feel less hopeless, so you can feel experientially what it's like to be less agitated. And once you have that experiential reference point, we're going to show you like 10 additional methods that you can use to reach that same experience of calm, that same experience of hopefulness, that same experience of resilience. And you can train those parts of your body to recall and relearn what it's like to feel that way. You can stimulate those aspects within yourself so that eventually you won't need the Prozac anymore because your body will be producing other substances that you need so that you can feel those ways without it. That would be using Prozac as an integrative tool. This can be done with anything from St. John's wort to surgery. So it's all on the orientation that you're teaching the patient about, with whether it's a mind-body treatment.
Mark, it sounds like you're sharing, what positive expectations there can be from the more traditional treatments or medication, or adding perhaps a placebo effect to what organically could be a helpful part of, let's say, medication treatment.
Well, I think we know from research that placebo accounts for at least 35 to 40% of all therapeutic effects, whether it's a medication or whether it's acupuncture. And yes, just placebo, but it's not only placebo. It's like I was saying before, it's the difference between, and I'll use an example of nurses. I don't mean this in a derogatory way. I have a lot of colleagues who are nurses who are wonderful clinicians. But let's say a nurse is about to give you a shot. What's the thing that you often hear them say before they give you the shot?
This is going to hurt.
Yeah, this is going to hurt a little. Imagine how different your experience would be if before they give the injection, they say, when you first feel the needle, that will signal to you that the healing process has begun. You're providing the same biological agent, but you framed it in an entirely different context that stimulates the patient's own self-healing. Is that placebo? Well, maybe, but it's all kinds of other phenomena as well.
Wonderful. Thank you for that.
Sure. So a little bit about resistance and defenses. Let's move on to the next slide. So, again, before we talk about treating, just to remind the audience, what we're talking about here is really, we're setting the stage. This is the foundation for the clinician of things that should be part of your platform that you're bringing to the healing encounter before we talk about any specific disorders. So part of it is, how do we understand the patient's readiness for therapeutic intervention? First of all, we have to keep this in mind. When a patient comes to you, they may or may not be ready for your intervention. Just because they've come to you, they may want help, but they may not be ready for it. So here's what I always keep in mind, this kind of scale. And on one side of the scale is, how much discomfort is the patient in? That's important for many reasons, not the least of which is that the level of discomfort is your therapeutic leverage. Their motivation for change is going to relate directly to how much pain they're in. Change is hard for many people. We all tend to avoid change. And we don't change unless we feel we have to. And distress is one of the biggest motivators of change. Now, what stands in the way of it? We all tend to fear change. Change is exciting, but change can be frightening. Our symptoms sometimes have a protective or a defensive function. Sometimes there's secondary gain from a symptom. A spouse that's and by the way, I believe secondary gain, when it's there, is almost always unconscious. It's rarely, the patient's rarely conscious of it. But, sometimes if there's a spouse, a patient who has headaches, who's in a marriage where they don't get much attention, and their spouse tends to be more attentive when they're in pain than when they're not, that may tend to may influence the course of the symptom. And so this motivation for change is important because back to what I said before, you don't want to be needing and wanting to change more than the patient does. That's a really good way for a clinician to burn out. I remember Carl Whitaker, who was the famous psychiatrist and family therapist, used to say, clinicians with missionary zeal will be eaten by cannibals. So, remember, the whole point being, if you need the change worse than the patient needs the change, you're not going to be effective and you're going to burn out. So what does that mean? That means that you present the therapeutic options, but be aware of the fact that you shouldn't be trying harder than the patient. What's an example of that? The patient I saw at the pain clinic back a few years ago was in a car accident, sustained soft tissue damage, fortunately no fractured cervical vertebrae. Went through a bunch of tests, went to a bunch of clinics, was still having the pain 6 months later, ended up at our pain clinic, and I did an evaluation. This guy was a stockbroker, worked probably 80, 90 hours a week. He walked into my office. I noticed right away that he had 2 pagers on one side of his belt and 2 cell phones on the other side of his belt. As I took the history, I found that he worked these super long hours. He would skip meals. He never saw his family. When I asked him about that, he said, well, I work long hours. I'm rarely home, but my family understands I'm doing it for them, is what he said. He drank about 8 to 10 cups of coffee a day, so he had huge amounts of caffeine, activating his nervous system and tightening muscles. But he said, Doc, I get to sleep late because I'm working so long, and besides, I really love my coffee, and on and on. So after the evaluation, I said, the good news here, Mr. Smith, is that I see a number of factors involved where if you wanted to make some changes, I think that this could really help your pain. And he said, Dr. Weisberg, I really appreciate that, but the fact is, as a stockbroker, I have to work this many hours or I'll lose clients. And, like I said, I love my coffee. And, I don't eat that well, but I make do with what I have, and bottom line is I need to work this many hours because it's been important to make that much money. I want to be rich. So, the knowledgeable clinician might say, studies show that people that drink a lot of caffeine tend to have more muscle tension, headache, and pain and agitation, or people who don't eat a good diet, tend to have more problems, or people who don't slow down and work no more than 40, 45 hours, get stressed out, blah, 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 would have been lost on this guy. So what I said to him was, you know what, that's fine. You're the expert on you, and my job is really just to let you know the options. But timing is really important, and clearly you have to work a lot of hours, and you love your coffee, and your family understands why you're gone so much, and this is what you need to do right now. Just keep in mind that in the future, if things get worse and you feel you need to do something different, there's other options. And that was it. He thanked me and he left. 3 months later, he came back to the clinic. Now his neck pain had expanded to severe headaches. He could barely get out of bed. The pain was so severe. He was at risk of losing his job. His wife was threatening to divorce him. And he came in and he said, now I'm ready. So in that 3-month period, that scale had tipped to where the discomfort had gotten worse, and thereby his motivation for change increased. He started our program then and made great progress because he was ready to do the things we asked. So really important to keep the scale in mind with every patient that you see. Just real briefly, this slide called Continuum of Treatment Techniques reflects the fact that what you do with someone with an acute problem is different than what you do with someone with a chronic problem. What we see here, that long arrow across the middle of the slide, is a timeline. So going from left to right, you can think of that as hours, days, weeks, months, years. The further to the right you go, the longer the time is. The more acute it is, for example, someone just breaks their leg or just had an injury in the past week, the more likely that any treatment that you use, any medication, any relaxation training, any hypnotic suggestion, any time management suggestion, any acupuncture, any stretching, anything that you use at that early stage is more likely to work. The longer the time passes, as we said before, it becomes more chronic, more complex. And if you are just trying to do something to make the symptom go away right away, the longer they've had it, the more likely that's not going to be successful. So you have to be aware of joining the resistance. You have to be aware of, as you mentioned before, aiming for small changes in the symptom. Sometimes you might even use a paradoxical technique, which is really joining the resistance, which is not really reverse psychology. For example, when I said to our stockbroker in the last example, it might be too soon for you to partake in this program because you're really busy. That's paradoxical in a sense, but it is also true. If I had said to him, no, you really need to do some techniques right now, the likelihood of it being successful would have been very small. So this is really just saying keep the treatment that you do, make sure that it's informed by how long the person's had the symptom. If it's a chronic symptom, you're going to use different techniques than when it's an acute symptom. If it's a chronic symptom and you're using hypnosis or EMDR or you're using a medication, the goal might be for them to have a reduction in pain from a 5 to a 4 or a 5 to a 3, whereas if they just had the pain a couple of days or a week or two, more likely you can do things to aim for alleviating the pain altogether. So that's the point of this slide. I made mention of this before. I think of all health and illness in terms of a psychophysiological pattern. I define it as a synergy of physiology, emotions, thoughts, images, one's sense of identity, behavioral impulses, and their sense of spirituality. So synergistic, meaning that these are all constantly affecting each other all the time. Fortunately, they're as individualized as a fingerprint, so everyone's psychophysiological pattern is going to be unique. These patterns are also holographic. So, Ed, maybe you could venture, like, how would you define a hologram?
A hologram would be that what is represented in one frame can be represented, in other parts of your life.
Yeah, right. Another way of putting that is that if you take a whole pattern and you isolate any one element in that pattern, that one element will contain the whole pattern. An example is a patient that was referred to me who had chronic chest pain. He's been seen by a cardiologist. Severe pathology had been ruled out. He was referred to me, and as I took a history, one of the things that he said is that I feel, I'm trying to remember what, this case was a few years ago. I feel held back in so many ways in my life. So I just noted that as part of the history. Then, in the treatment, I used a technique where I had him just focus on the sensation without trying to change it. And the very first thing that he said to me is, it's a holding me back kind of feeling. So that's just an example of that hologram. You break it down to its smallest element, and there's that whole feeling again. So these patterns are holographic, and that's good to know because as a person focuses on any part of their psychophysiological pattern, their sensations, their thoughts, their emotions, their images, those things are going to reflect the whole pattern. And when the patient knows that, it makes it easier to then have some inroads to change the symptom. And symptoms, of course, provide us some information about what these patterns are. Why is this important? The notion of a psychophysiological pattern is important mostly because when a patient knows what their psychophysiological pattern is, they can start to work with it. When they know the emotions, the thoughts, the images, the physical reactions they tend to have with their symptoms, they can kind of get to work on it. It's like, oh, I've got the stomach ache again. I know that I have these emotions attached. I know I have this kind of sensation. And they can work with any of those aspects and start to work with it. So it's a very empowering tool for the patient and for the clinician as well. All right. So what we just talked about is part of the foundation. Now here's another part of the foundation that people need to know. Ordinarily, if I was in a live audience, I'd be asking the participants how many of them know this term. But for those in the audience who don't, I really encourage you to read up on it. The term is Psychoneuroimmunology. This is the how and why of why mind-body medicine works. Let me just recommend right off the bat a couple of books that are really helpful on this topic for people who want to learn more. One is called The Psychobiology of Mind-Body Healing. I'll repeat that. The Psychobiology of Mind-Body Healing. The author is Ernest Rossi, R-O-S-S-I. And the first half of that book is a really great review of psychoneuroimmunology down to the molecular level. That's readable and is really a helpful guide. There's another book called Psychoneuroimmunology. which is edited by Robert Ader, A-D-E-R. And that's one of the kind of classical textbooks in this field. I think if you now if you even Google the term, you can access a lot of information. I'd mention one other author too, Louis Cozolino, C-O-Z-O-L-I-N-O. He's written a few books, and if you Google psychoneuroimmunology and Cozolino, you'll get to some of his work, which is also very helpful on this topic.
And I'd like to interject, Mark. I have read these books, and especially Louis Cozolino's book. He really brings it to everyone on a personal level with wonderful case studies that he was involved with. So it really is a very user-friendly way to understand psychoneuroimmunology.
Yeah, yeah. All right, so let's make sure we have a common definition here. When Robert Ader first coined this term, he actually discovered it by mistake. He was working with rats, as experimental psychologists are often known to do, and he was checking to see their reaction to cyclophosphamide, which is an appetite suppressant in mice. And what he found inadvertently in these mice and rats was that the immune system could actually be classically conditioned. The rats' immune system was suppressed when they took the cyclophosphamide, but then when he gave a placebo substance that had the same smell as the cyclophosphamide, the rats also showed a decrease in immunity. So this recognition that the immune system can learn was a huge development. He came up with this definition of psychoneuroimmunology: the study of bidirectional interactions between the mind and brain, the nervous system, hormonal system, and immune system. Keep in mind, too, that this field took birth right along close to the beginning of the AIDS crisis in the United States. And during this time, the federal government spent billions of dollars on researching the immune system. And before this, we knew relatively less about the immune system. And it's because of the AIDS crisis, our knowledge of the immune system expanded rapidly. And so a kind of a broader definition now is that the mind and body are united by messenger molecules. For example, neuropeptides that Candace Pert talks about. Neuropeptide basically means a protein that is innervated by the nervous system, and that these neuropeptides flow through the cerebral spinal fluid throughout the body and communicate so that all parts of the body communicate with all other parts of the body. It's the common communication between thoughts, emotions, sensations, and broken down to the molecular and genetic level of the body. It was quite a exciting finding, and this is part of how mind-body communication occurs. Next slide, please. So, as I said, with the AIDS crisis, we learned a lot more about the immune system. Previous to this, common classical medical thought is that there was no relationship between the nervous system and the immune system. Now we know that the organs of the immune system, which are primarily the thymus, located in the chest, bone marrow, spleen, and the lymph nodes, are innervated by the sympathetic nervous system. and that the sympathetic nerves make contact with white blood cells. So physically, the brain is connected to the immune system. Therefore, the nervous system, which is involved in the mediation of feelings, is connected to the immune system. That might sound obvious now, but until before the 1980s, we didn't know this. So this is a recent development and really spurred on this field. Next slide. So we're talking about pretty complex concepts here. How do you convey this to a patient? Well, one way is I might show this diagram to a patient when I'm starting to explain this. And by the way, I do explain psychoneuroimmunology to all my patients. I break it down into language they can understand. And I explain what the limbic hypothalamic axis is. I'll get to that in a moment. But what we're looking at here is what you might call top-down communication. So looking first at the cerebral cortex, events on the cortex such as thoughts, emotional impulses, that sort of thing, channeled down through what's called the limbic brain underneath the cortex. Something very important happens there, which is that electrical impulses from the cortex of the brain are converted to hormones. They're converted to hormonal messenger molecules that then communicate to all these other systems of the body, the nervous system, the hormonal system, and the immune system. Next slide.
Oh, hello. This is Heather Butts, actually. I had a quick question for you, if that's okay.
Sure.
Wonderful. Not to get you too off track, but this goes back a little bit to the point you were making regarding individuals who, the stockbroker example that you brought up, and it kind of ties in a little bit with the lymphatic system. You mentioned that you get patients sometimes who they either have their own sort of resistance issues, or conversely, they may have families that have issues regarding resistance. I was wondering if you could speak a little bit to not so much the patients that are having issues regarding resistance, but if they have family members who don't necessarily want their lives to change because that will mean that the lives of the whole families are impacted.
That's a really interesting topic. I'm going to let me make a quick comment about that because I don't want to get too far off from this psychoneuro stuff. But let me give a quick example, and then we can be sure to talk more about it. It's a really important topic. Here's an example. A very interesting finding is they were doing a study of people who failed treatment for fibromyalgia pain. So, fibromyalgia is this condition where people have widespread pain throughout their body, fatigue, depression, sleep disturbance, all that stuff. And they did the study and said, let's see if we can identify what's the number one variable that predicts failure in chronic pain treatment. And again, they looked at all these, they looked at the different types of diagnoses, they looked at how many medications they were on, their age, socioeconomic status, all this stuff. The number one variable that predicted failure in chronic pain treatment is if the patient had a spouse that treated them in the sick role. Now, what does that mean? The sick role, of course, means that when a patient's in a sick role, that the spouse is treating them really as being more sick than they really are. So the sick role is, I don't feel good, and, can you get that for me, and I can't go to work because I don't feel well, and can you go to the store and get this for me because I can't do it, and the spouse says, honey, don't get up, let me get this for you, and basically enables their spouse inadvertently to do less and less. Sometimes because the spouse of someone with chronic pain, especially if they have their own problems or issues, or if they've have problems feeling a lack of value or worth, sometimes when they become a caretaker of someone who's sick, they feel some sense of purpose or value. And so inadvertently, they may actually need their spouse to stay sick. This is usually not a conscious awareness, but they end up treating their partner as sicker than they really are. And you can imagine how that could really start to interfere with their progress in treatment. Does that give you an example?
That's fascinating. I was thinking about the enabling spouse, and you obviously, with your expertise, put it much more succinctly than I could have.
It might be a spouse, it might be a parent, it might be a work associate or a boss at work. It can be anyone in the system, but wherever it is when that takes place, that's one example of how the system can start to interfere with progress.
Yeah, I just thought about it because of your stockbroker example, where you could have family members who wouldn't be too happy with the stockbroker stopping to work because that impacts on the family's income in an interesting kind of way. So you could have different forms of enabling because it helps the family structure stay dysfunctional.
Right, exactly.
Thank you.
You bet. Now, we were talking before about communication from the cortex, our thinking rational brain, down. But remember, this is bidirectional communication, so sometimes the communication can be from the bottom up, meaning from the lower brain structures up to the cortex. As you can see in this diagram, the structures further down in our brain towards our brainstem and spinal cord have less concentrations of neurons, and as you go up the brain towards the cortex, there's a much higher concentration of neurons. So what's an example of bottom-up communication? Let's say you're at a picnic, and it's summertime, and there's mosquitoes, and you're talking to a friend, and next thing you know, you find yourself swatting at mosquitoes and saying, "Oh, it's kind of buggy." What you don't have to do is to stop. If it was from the top down communication, you'd have to say, "Wait a minute. I think there's bugs here. I have to stop talking to you. I have to activate my deltoid muscles, my biceps, my triceps, my latissimus dorsi, and my trapezius muscles. I have to raise my arm and swat at the mosquito." Of course, that's not what happens. Instead is you're swatting away, talking to your friend, going, "Wow, it's buggy. What happened there?" The information first came in as a reflex. So the brainstem, that primitive reptilian brain, was the first part of your brain that got the message. And that sends signals up to your limbic brain and finally up to the cortex that said, "Wow, it's buggy today." But you were already swatting at the bugs before you even thought about it. For the participants in the course, how often have you heard a patient say, "I know I shouldn't feel this way, but I do anyway"? Whenever you hear someone saying that, this is an example of bottom-up communication. They know I shouldn't feel so scared, but they do anyway. How often do we hear people who have post-traumatic stress disorder say, "I know I shouldn't feel this frightened and terrified, but I do anyway"? I know that my fear that someone's going to break into the house and attack me is irrational, but my body feels like it's going to happen anyway. This is bottom-up communication. So just a reminder that communication goes in two directions, and that for effective healing, we have to be aware of dealing it from both directions. And this is why methods that engage the brain at levels below the rational cortex, things like hypnosis or EMDR or somatic focusing or other treatments like that, are effective because they engage the brain at these deeper levels. and in some ways bypass the cortex. As I often tell my patients, the rational brain is often the last to know. So, okay, so I'm going to take, Ed, let me ask you a procedural question here. How long do we have before we get to questions at the end?
I would say we have a good 15 minutes for you to continue with your presentation. Maybe leave 5 to 10 minutes at the end for folks to ask questions. And for those of you that really think of something later on, you can email us at info@mindbodymedicinenetwork.com if we don't have enough time for your questions. So I'd say about 15 minutes or so.
Okay, good. So this next slide reminds me of another book that I'd recommend to the participants. The book is entitled The 3-Pound Universe. It's written by Paul MacLean, who is a neurobiologist and is a must-read. His notion here in the 3-pound universe, of course, is referring to the brain itself. What we're looking at here is a diagram of, if you can imagine a brain sliced in half. The left side is the anterior or front of the brain. The right side is the posterior or back of the brain. And this is an evolutionary model, meaning that that first layer that's in black, the primal brain, is what developed first. This is what he calls the reptilian brain. This is the brain that you'd find in a current-day reptile. And that's what developed first. And we all have a reptilian brain. Even though we're human, we respond to territoriality and reflexes and things like that. So we all have that level of brain. The next level that developed was what's called the emotional brain. This part includes things like the limbic system, which we'll discuss in a moment. Understanding the limbic system and the limbic brain is very important because structures in the limbic system mediate our emotional experience and are also very important for anyone who's dealing with pain. In the limbic brain, there's a structure called the thalamus. And the thalamus is really the sensory input from the spinal cord. So all sensory information, sight, sound, pressure, temperature, sensation, all those things come up through the spinal cord and into the thalamus. From there, it goes into another structure called the amygdala. And the job of the amygdala is to assign emotional significance to whatever sensory information comes in. So, for example, here in the Twin Cities, I don't know if this happens in New York or Atlanta, but here they set off the civil defense sirens once a month just to test them. So Wednesday at 1 o'clock, first Wednesday of the month, they set off the civil defense sirens. So if it's Wednesday at 1 o'clock and you hear the civil defense sirens, you hear them and you go, oh, it's Wednesday 1 o'clock. It's a test, and you don't have any reaction to it. However, if you hear that same civil defense siren at 3:30 a.m. on a Sunday morning, you're going to have quite a different psychophysiological reaction to hearing that siren. You're going to be alarmed, you're going to be scared, you're going to jump out of bed, you're going to turn on the TV, you're going to see what the heck's going on. What happened there? The amygdala, whose job it is to assign threat value, heard that sound, that siren, the same siren that it hears 1 p.m. on Wednesdays, and said, this siren signals danger, and it sets off alarms in the body. This is what happens often when people have pain. They'll experience a sensation, and then the alarms go off. Could be a pain in the back, pain in the shoulders, pain in the head, wherever. They've already been told that it's due to nothing serious, but their reptilian brain and their amygdala get triggered and say, uh-oh, we're having an emergency, and sets off panic and tension and stress hormones. So this is helpful to know because when I see a patient who has headaches, and I take a family history and ask them about their psychological history, and they say, Dr. Weisberg, I'm here because of headaches. Why are you asking me about my emotional state? The answer is, it's because of the way that our brain is wired. That sensation and emotion are combined and connected in our brain. This is why scientific definitions of pain are, pain is described as a sensory and emotional experience for this very reason, because of these structures in the brain. So that's why it's important to know about this. When you tell a patient about this, they become much less defensive and much less likely to think that you're calling them psychosomatic if you bring up emotions in regards to their pain. Finally, this last level, the rational brain, developed, from an evolutionary standpoint, developed later, and of course allows us the ability to do rational abstract thought. So, next slide, please. Real briefly, I'm assuming that the participants know this, but our patients usually don't. We have what's called the autonomic nervous system. I tell patients you can think of autonomic nervous system being the automatic nervous system. It's that branch of our nervous system that operates without our having to think about it. It's what keeps our heart beating. It's what causes our liver to secrete bile to help digest fat. All these automatic functions in our body. It's two branches. Sympathetic, which is the activating branch, you can think of it as the gas pedal. Parasympathetic branch causes the system to relax. You can think of it more as the brake. When these two branches of the system are in balance, things go well. When they're not in balance, then any physical symptoms that we have are likely to get worsened. I think it's interesting to notice here that when the sympathetic branch, by the way, when the sympathetic branch is fired up, we have the fight-flight reaction. And notice that during that, heart rate goes up, salivary flow goes up, the stomach motility goes down. We think this is because, when you're in threat, your energy, the lymph, and the blood go more to the extremities to prepare to fight or flee. Or as a friend of mine once put it, you're not likely to be thinking about lunch when you're about to become someone else's lunch. So that's a good way to remember that. Next slide. Real quickly, another really important concept for clinicians to know is the hypothalamic pituitary adrenal axis, also known as the HPA axis. This is what gets activated with the stress response. In this example, in this slide, we start with events on the cerebral cortex, our thinking, our rational logic. And it's the perception of stress, either from an external source, which could be anything from bumping into an intruder on the street, being late for work, dealing with a difficult boss, a difficult partner in a relationship, financial stress, environmental stresses from hurricanes or things like that. Or it could be internal stress. It could be someone who's hard on themselves, someone who anticipates that bad things are going to happen or that they don't deserve good things. It doesn't matter whether the stress is external or internal. Once it's perceived, cerebral cortex says, uh-oh, we have a problem, and it sends electrical impulses down to the hypothalamus, which is in the limbic brain that we talked about before. The hypothalamus says, uh-oh, we got a problem. I better release corticotropin-releasing hormone, CRH. That hormone is released and is picked up by receptors in the pituitary gland, who says, uh-oh, pituitary gland, by the way, is at the base of the brain. It says, uh-oh, we got a crisis. I better release adrenocorticotropic hormone, ACTH. ACTH is secreted and picked up by receptors on the adrenal glands located on top of the kidneys. Adrenal glands go, uh-oh, we got problems here, we're in crisis. I better release stress hormones like cortisol, like adrenaline. So the stress hormones are secreted, and so the body now has higher levels of adrenaline and cortisol. So Ed, when you get higher levels of adrenaline and cortisol, what are you likely to experience?
More rapid heart rate. My body temperature rises. My breathing changes. I feel stomach discomfort.
Right, exactly. Those are just some of the changes. So when that all happens, then our rational brain goes, geez, I feel awful. Wow, this problem's really getting hard. This stress is really difficult. We're in crisis. I'm going to send electrical impulses down to the hypothalamus, and then you get the vicious cycle going again. So this is what happens in the stress response. And our job, using mind-body treatments, is to interrupt that cycle in some way so that they don't have this going on continually.
So, Mark, that leads us to a question in our chat area. What methods would you use with a client or patient in a session to facilitate an experience of mind-body integration? And then also, what homework assignments are recommended? And this comes from Larry Camerata.
Okay. Thanks for that question. And Larry, I wonder if we may have met before because your name sounds familiar. At any rate, one real quick, there's really unlimited numbers of methods. I'll mention one quick one, and maybe I'll have time to mention a few more. One of the quickest methods that I like to use is 4-4-8 breathing. And what that is that you inhale for 4 counts through your nose, hold it for 4 counts, exhale for 8 counts through your mouth. When I have someone do this, I'll have them rate their tension level before they do it. And then I'll show them I'll model it once, in for 4, hold for 4, out for 8. I'll have them do it once and make sure that they've learned how to do it. Then I'll have them do it 10 times. I say to them, while you do it, keep your eyes closed, keep your attention on the counting, and do this 10 times. That cycle of in for 4, hold for 4, out for 8. Invariably, after they do that, and it takes about 2 minutes tops for them to do that 10 times. Invariably, after they've done that, 98% of people will describe that their attention level's gone down from a half to almost entirely. I like this because it's really quick. I like this because it's simple. People can learn it easily. And then I'll tell them to practice it 3 times a day. The nice thing about that is, in terms of compliance and having people follow through with homework, this is a real easy way to start homework. You're asking them to do something that's taking a total of 6 minutes a day. So if someone comes back and they say they didn't do it, you know that there's some reason other than that they didn't have enough time. So it's also a good way to screen for people's readiness to participate in treatments. It also is, every now and then you'll find someone who may become a little more tense. It rarely happens, but does on occasion. And when that happens, you might know, oh, this is someone who has some trauma history or some other way in which relaxation for them is threatening, in which case we work more slowly with them. But that's an example of a quick, effective integration method to use that's easy for them to do as homework. Ed, I think for the sake of time, I'm going to skip past this slide. If people want to know more about autoimmune disorders, they can feel free. I'll be happy to answer any questions you pass along. This is just to recognize that the way that we modulate and self-regulate can be top-down or bottom-up. Here's top-down. What's an example of that? If I'm really tense and I decide to do that 4-4-8 breathing, I'm making a conscious decision coming from the cortex that I'm going to calm myself down. Then I do the breathing, and then the lower brain regions, the more primitive brain regions, start to calm down. Next slide. Sometimes the influence is from the bottom up. So, for example, if I'm late for work and I'm driving and there's some 95-year-old man in front of me who's 4'6", you can barely see his head above the steering wheel, driving 6 miles an hour, and I can't get around him, I'm going to start thinking, oh, why do I let these people drive? And I hate to let these people drive, and I'm going to be late. However, if I've had the opportunity before I got in my car to do some exercise or some meditation or some self-hypnosis, I may find that once I'm in the car in this situation, I might not react with as much tension or as much impatience to the same situation. There, the lower brain regions that have already been calmed by the hypnosis or the relaxation influence the higher regions of the brain to think calmly and less critically. So the influence can go in both directions. Let's see. Let me just check one thing here, Ed, because based on the time, I want to see, I'm just going to look ahead at the slides to see if I go individually into these slides or not. Okay, so here's what I'm going to do. I'm going to just talk briefly about these structures right now, and then we can skip ahead a few. All these structures that are being pointed to are pointing to structures, are parts of the limbic brain. People can see that the limbic brain is located in that top pink area underneath the cerebral cortex. The hippocampus is important because it has to do with memory. And so anyone who remembers what they ate for lunch today can remember that because their hippocampus encoded that information. However, the hippocampus has a high concentration of receptors for stress hormones like cortisol. So when we're under high levels of stress, it changes how the hippocampus stores memories. And when we're under extreme stress, like trauma, sometimes the hippocampus fails in its ability to store a memory in a way where we can recall it rationally, and instead stores it further down in the brainstem, so we experience the memory as a flashback or as a bodily memory or as some physical symptom. So understanding the relationship between the hippocampus, memory, and trauma is important. The amygdala, as I mentioned before, ascribes emotional meaning to events. However, the amygdala kind of has a loose grip on reality because the amygdala can't discern between a real threat versus the perception of a threat. This is why we get scared at a scary movie. When we're at a scary movie and we see the guy's got the knife and he's hiding, he's going to come out, we're on the edge of our chair, we're white-knuckling, and our heart rate is picked up, even though there's no actual threat. This is why I tell my patients that there's parts of our brain, like the amygdala, that don't know the difference between an actual event versus the memory or the image of an event, and will create the same physical reaction. Okay, that's really important to remember. And it's important to remember because we can learn to speak to the amygdala. We can teach the amygdala that something that it's signaling as a threat is actually not a threat. If someone has tinnitus or if someone has a headache and they have a panic reaction because they're afraid that this means they have a brain tumor even when they've been told that they don't, you can use a calming voice, you can use information, you can use hypnotic language, you can use breathing exercises to train the amygdala and related structures that this sensation is no longer a threat. So the big point here is that these structures, the hypothalamus we've talked about before, and the pituitary gland converts to hormones and sends these messages to the rest of the body. The big takeaway message here is twofold. One is participants should learn more about these brain structures that I've listed. And number two, neuroplasticity. The brain has plasticity. It can change. And we can teach the brain to change, and we can teach the brain to respond differently to emotions and sensations. So that's the main point there. So I'm going to go ahead and have you skip the next few slides. Skip this one. People can read back on it. Skip the hippocampus, the amygdala we just talked about. And we skip that one too. For our purposes at this point, looks like we have about 5 minutes, Ed, is that right?
Right, and feel free if you want to go over some, that's just fine. And for those of you that haven't had your questions answered, you can email us at info@mindbodymedicinenetwork.com. So please feel free to go beyond our time limit if you'd like.
I think what I'd like to do, because I actually have a commitment where I'm going to have to leave shortly after the end of the time. Let me just make a comment on this slide. I'd like to open it up to some questions before we stop. And then people have the rest of the slides that they can refer to, and I'll be happy to respond to questions by email afterwards if they'd like. The whole point here about hypnosis and psychoneuroimmunology is hypnosis by being able to quiet the rational brain and communicate to the right temporal lobe, right frontal lobe, and the limbic brain has a way of speaking to the reptilian brain and the limbic brain in a way that can cause deep, lasting change. Hypnosis is particularly helpful when dealing with trauma, when dealing with other types of habitual reactions where the person's saying, I know I shouldn't feel this way, but I do. Hypnosis has been shown to create profound psychophysiological changes. The hypnosis can change immune parameters, can change white blood cell count. Hypnosis can change heart rate. Hypnosis can change blood pressure. Hypnosis can change skin reactions. There's no physiological system that is outside the realm of hypnotic interventions. Now, it's not the only treatment that can do that. There are somatic experiencing and some other types of energy work that can do that too. But hypnosis is particularly well suited. Bottom line being, for any of you who are new to hypnosis or have not learned it, I would really personally invite you to learn more about this, because it's a powerful tool. When it's learned properly, it can be really, really helpful for mind-body interventions. So with that, maybe we can take about 5 minutes and open up to a few questions before we stop.
That sounds wonderful, Mark, and I want to thank you for an outstanding presentation. And this would be the time, folks, where if you wanted to put a question in the chat area, you're welcome to. If you want to ask afterwards, you'll see in the chat area. You can email us at info@mindbodymedicinenetwork.com. But I would like to ask Heather if she had any questions, our producer for this evening.
Yeah, the presentation just gave was really wonderful, and so much information. I can't thank you enough. I was struck by the example you gave regarding the systems you have, where you live, where essentially the emergency systems. And it's interesting because before the talk we were talking about 9/11, and here in New York they have a system through nyc.gov where you can get text alerts when they're going to be like overhead of fighter planes or something happening that might make people nervous. And this was this is in direct response to the fact that the NYPD was getting a lot of calls from people when there would be planes or low flying planes or helicopters. They would get a spike in calls because people were so nervous post 9/11. And so I just was wondering if maybe you could talk about that a little, because 9/11 now, it's 10 years later, and people are still having these visceral reactions. And maybe you could talk a little bit to that phenomenon.
Sure. Well, that's one of the areas where mind-body interventions are just so powerful and so helpful is in treating post-traumatic stress disorder. And interestingly, among my patients, some of them developed post-traumatic reactions and some didn't. But part of what can happen is that when there is post-traumatic stress, which is defined as someone is exposed to an event that is either life-threatening or potentially life-threatening, or they witness someone going through an event that is life-threatening, they go through these series of reactions, which can include nightmares, flashbacks, and your autonomic nervous system becomes hyper-aroused and oversensitized. When that happens, it's important to remember that we talked about the limbic brain. Structures in the limbic brain, like the amygdala and the hippocampus and structures like that, have no time reference. Our rational brain can say at 7:30, we started at 6 o'clock, we've been talking for an hour and a half. But the limbic brain does not have any time reference of past, present, and future. Everything's now. So this is why when someone's having a post-traumatic reaction, the feeling will be, I've always felt this way, I feel this way now, and I always will feel this way. That's because of how the limbic brain responds to trauma. And so techniques, and certainly EMDR can be used, guided imagery can be used, but for example, I had a patient I treated just this past week who encountered some trauma it was from physical abuse. But actually, let me use an example from 9/11. I had a patient who was actually flying out of New York that morning, and she was in the air when the planes hit the towers. And she was heading from New York to Minneapolis. She was midway in flight, and the captain gets on and says, "There's been a national emergency. We have to land immediately, and I can't tell you anything more." Can you imagine how you'd feel if you were on an airplane and were given that message?
Horrifying.
And not knowing anything more. And so understandably, she became afraid of flying, as many people might, having heard that message. They landed somewhere in Wisconsin and had to take a bus back to the Twin Cities. So in hypnosis or using other kinds of treatments, you can give an opportunity for the person to respond in a way that they can complete the response pattern that they couldn't before. Because what happens when you get traumatized is you often go into a freeze response, like a deer in the headlights. You remember looking at the coverage of 9/11, how so many New Yorkers just stood there stunned, staring at the buildings. It's like they were frozen. They were like deer in the headlights. In hypnosis or in other similar kinds of treatments, you have the opportunity to take the person back to that experience with help, with other helpers, and with the notion that you now have the opportunity to resolve this experience. You now have the opportunity to go back there and soothe and calm that person who was sitting in that plane 10 years ago, who had a panic attack, who went into a freeze. And you can sit there with her now and say, it's okay, and you're actually all right, and we came through this okay, and you came through it okay. And the deepest part of your brain can learn this and know that you're safe and that you're going to be all right and that you're secure. Now, to the rational brain, it goes, huh? No, I'm not. I still feel awful. But to the limbic brain, that message says, thank you. That's exactly what I needed to hear. And now I can turn off the threat signals, and I no longer have to signal to the body that we're under threat. So that's an example of how we might use a hypnotic kind of intervention to help reduce the trauma response for someone who went through something like 9/11.
I applaud you, because that sort of imagery, it's just so amazing. And I think usually when we think about, trauma and so forth, we think about sort of like dealing in the now and trying to have to sort of recover, but you sort of put together something that really sort of almost takes you back to the time, and then it's sort of helping the person at that time and then moving forward, which is a very hopeful message.
Well, you have to, because that the part of the brain that's causing the post-traumatic reaction is stuck back at that time.
Right.
And so you have to meet them where they are, which is at the point of the trauma, and give them an opportunity to complete their response. And when they can complete their response, they can let the trauma go.
That's wonderful.
So
thank you so much.
For any people who have questions, you can feel free to, as Ed mentioned, go to the Mind-Body website. You can also reach me for questions at my website, drmarkweisberg.com, and get updates about when the book Trust Your Gut will be released. And to Heather and Ed, I just want to say thank you so much for inviting me to do this. It's been a pleasure. You guys have been great to work with, and this was really fun.
Thank you so much, Dr. Mark Weisberg, the person who really gave me the most training to really build up my mind-body medicine practice as well as network. And I thank you for sharing with others what I've received from you for many years. And thank you so much for your contributions to the field of mind-body medicine, health psychology, clinical hypnosis. I can go on and on, but you have been a pleasure to have featured in our webinar this evening. I thank you so much. I thank Heather Butts, our producer. And again, Dr. Mark Weisberg's website is listed here, www.drmarkweisberg.com. And do check his website for updates about his upcoming book, Trust Your Gut. Everyone have a wonderful evening. Thank you for joining us, and a happy holiday season and a happy, healthy new year to one and all. Good night.